Yeah, so ICL sizing, new formulas and OCT based sizing is the way to go is what I'm going to defend, no financial disclosures. So we all know why is sizing important, because it's the single most important determinant of the post-operative vault, which we want to be within 250 to 750 microns ideally. So what is conventionally used and recommended by the manufacturers is an online calculation and ordering system, which is based on the white to white and endo ACD, and the white to white is measured by calipers, topographers or optical biometers. So why is it inadequate? Despite all these, more than 20% of patients do not achieve the ideal vault after surgery. In fact, one of the largest series in which they explanted 2.6% of their fake AIOS observed that low vault was responsible for 50% of cases of explant and high vault for the remaining 50%. So what are the alternatives? White to white has a poor correlation with the actual sulcus to sulcus diameter where your phakic isle is going to rest. Sulcus to sulcus directly measured using UBM is accurate, however, has high inter-observer variance and low repeatability with a lot of potential sources of error. Angle to angle measured using OCT significantly correlates with post-operative vault and ICL size and angle to angle distance and has a higher reproducibility than the white to white measurements alone. So swept source OCT, which gives you a 3D reconstruction of the anterior segment, is useful for ICL size determination because of the automatic analysis and is more accurate and repeatable. So we have a host of new OCT based formulas, KS formula, NK, Lasso, Kang, etc. based on swept source OCT using different machines which take into account different parameters and the newer parameters as well, including the crystalline lens rise, the distance between the scleral spurs, angle to angle distance, and the lens thickness as well. So just to highlight a few cases of why where we are is still not enough. This was a case in which both eye 13.2 mm ICL was implanted based on the conventional nomogram. Post-operatively, we had an excessively high vault with appositional angle closure. This was a second case in which a 12.6 mm ICL was implanted and we had a very low vault of 209 microns, which is expected to further decrease with time as well. Another case in which bilateral implantation of toric ICL was done. Post-operative day 1, the ICL rotated 90 degree. We did reorient it and rotate it, but if you see, even after reorienting while hydrating, it was rotating, and after rotation also, it was again misaligned. So it was exchanged with one size larger ICL, and then is when we achieved an adequate vault of 722 micron with a well-oriented ICL at 175 degrees. So in this case, the rotation was occurring despite an adequate vault of 600 plus. It was not a 100-120 vault in which you will expect a toric ICL to rotate. So it was not undersized compared to the conventional nomograms, but the sizing was still not adequate. And on further analysis, we observed that the crystalline lens rise in this case was minus 298, which is much less than normal. Maybe that is why it was equating with an adequate vault when it was in fact smaller. So conventional sizing has issues galore. We often get information from the manufacturer that the lens size you have chosen, maybe there is a disparity between two eyes, or it's the biggest size, it's the smallest size. So we still have not hit the sweet spot. So perfection is not attainable, but if we chase perfection, we can catch excellence. So the conventional sizing needs to go out. Thank you for a patient hearing.